Hello, I'd like to welcome everyone to our podcast entitled Alcohol-Associated Liver Disease, a Growing Problem. I'd like to welcome my co-discussant, Dr. Mack Mitchell.
Thank you, Steve. It's a pleasure to be here with you today.
And my name's Dr. Steve Flamm, and I'm from Rush University in Chicago and a transplant hepatologist. Alcohol-associated liver disease is a very, very common problem, Mac, in society. And there are some issues that have been really growing in importance and relevance that I think bear importance for discussion. And we're going to talk about some of them in the next few minutes. And those include treatment of alcohol-associated hepatitis, the importance of a multidisciplinary approach for alcohol use disorder pre and post liver transplant, transplantation of alcohol-associated liver disease in the acute setting, and talk about the growing recognition of MET alcohol liver disease, MET ALD, in the field. So, Mac, welcome again.
Thank you.
And let's start off a little bit with what do you think about the growing prevalence and incidence of alcohol-associated liver disease? Have you noticed this in the last number of years?
You know, Steve, we've known that alcohol causes liver disease for decades. I mean, that's not news. But what is new is the fact that more people seem to be drinking at levels that are putting them at higher risk for developing liver disease. And I think one of the big contributors there is the fact that we have an epidemic of obesity. And in the setting of this epidemic of obesity, when people are drinking, that's an additive risk factor. It's an additive risk factor for the development of steatotic liver disease, or fatty liver disease as it used to be called. But both alcohol and obesity contribute to that problem. And you've said often that you feel that alcohol really is the number one factor that contributes to progression of liver disease. And I know you see this a lot in your practice.
Yeah, we do. In Chicago, we see this a tremendous amount, exactly what you're saying. There are certainly people that have pure alcohol-associated liver disease. They're thin, they don't have any metabolic syndrome problems, and yet have alcohol-associated liver disease. And then there are others that have pure fatty liver, MASLD, metabolic-associated steatotic liver disease, but there often is an overlap. And you certainly see patients that are obese, have diabetes mellitus, and drink. And it does seem, in my practice, that patients who have all of those factors, including the alcohol, that they do seem to have a worse outcome in the end. So as a practitioner, I think practitioners have to be aware of this and really attend to all of these different risk factors. Do you do anything special when you see a patient that comes to you with, alcohol-associated liver disease and have components of fatty liver?
I do. And, we're getting a lot of referrals these days for patients who have been diagnosed with fatty liver disease, typically on an ultrasound or because they have some minor abnormalities in their liver enzymes, and they're sent in for evaluation. And, it's really important that we take a comprehensive look at their lifestyle and what they're doing. Most of them are obese or at least overweight. But when you really start talking to them about their diet, it's important to ask about their alcohol consumption. And I think very often people are uncomfortable asking those questions, but without asking those questions, we won't have the information that's necessary for us to guide patients in terms of what to do to correct these situations. And I think the way that we should ask that is not only how much do you typically drink on an occasion when you are drinking, but how many times a week do you drink alcoholic beverages? And by doing it in that fashion, we're getting a quantity frequency measure of their overall consumption. That doesn't get into the whole issue of whether they have alcohol use disorders, but that's not initially relevant. It is relevant at some stage, but initially you really want to understand how much is somebody consuming, because we can make a difference in that.
We know, Mac, too, and I'm sure the providers watching the podcast today have seen this as well. Patients aren't always honest about their alcohol use. And even when you do ask them, the answers that they give are not always truthful or consistent. Not that they're always lying about it, but I think they minimize the amount that they drink, and sometimes they do not tell you the truth. Do you use any blood tests when you evaluate patients where you really want to have a better idea of patients have problematic alcohol use?
We do. And I think that we're fortunate today that we do have the so-called PEth test, the phosphatidylethanol test, available. It's a blood test, and it can be ordered now through Quest, through LabCorp, and most other hospital laboratories offer that. And it's a good way to confirm what the patient is actually telling you. I do like to rely on their self-report, but I recognize very clearly that it's easy for people to underestimate or forget or not really measure when they're drinking. And the PEth gives you a way to correlate what they're telling you with what the test is telling you. And when you put those two pieces together, if they are discordant, then it's time for a deeper conversation.
And how much drinking do you have to drink, or how much alcohol do you have to drink, and over what time period to light that PEth test up, just for the providers?
Yeah, that's a really good question, and I think there's some evidence on that. And one of the things that's interesting is that PEth tests where the level is above 20 and up to the 200 range, or maybe 25 up to the 200 range, do really seem to correlate with drinking at levels that are at or above those levels recommended as the maximum by the National Institute on Alcohol Abuse and Alcoholism. And they say that for men, that's roughly 15 drinks a day, or for women, it's for 15 drinks a week. And for women, that's 8 drinks a week. But they also look at this by the day. And if it's more than 5 a day for men or 4 a day for women, that's considered heavy drinking also. So those are the ranges. And when you see these elevated PEth tests in that range, that's when you need to be careful about recommendations that you make to people about their continuing consumption of alcohol.
And two, even if you drink less than that, if you do have concomitant metabolic associated steatotic liver disease, this MET ALD, you can have, would you not agree, more progressive liver disease than you do with either one of the two disorders in isolation.
Absolutely. I think, in some ways you can almost think about this as the old adage of this is sort of like gasoline on the fire. You've got the smoldering cardiometabolic risk factors that have been there probably for a significant period of time. And the drinking on top of that really does add to it. And one of the things that is noteworthy is the fact that there are a lot of younger people these days who are overweight or obese. And we know that most people consume more alcohol in their 20s and 30s than they do later in life. So that's one of the reasons I think we're seeing so much more significant liver disease in younger patients because they are at that age where they are drinking more heavily. But when we come back to this whole idea of when you're talking to somebody about these problems, I think it's important to recognize that we need to meet people where they are. And we want to particularly avoid the idea of stigmatizing the consumption because it is a part of our society. Our society drinks a lot of alcohol, and it's part of how we socialize with other people. So before we start being pejorative in our use of terms like alcoholic or this person just, drinks too much and why don't they stop and all those kind of things, think about the fact that it is a big part of our societal, activities, and just recognize it for that, and then help guide people in terms of both their diet and their alcohol consumption.
And when in our mind we think someone does have alcohol use disorder, either in isolation or in combination with metabolic associated steatotic liver disease, I know you have stated in the past, and I believe this fully, we in the healthcare provider community have not done a very good job of taking care of the alcohol use disorder aspects of their disease. And would you mind commenting on a few of the things that you think might help patients have better clinical outcomes if we attended to them better for the alcohol use disorder, not specifically for the liver itself.
Yeah. So, as we were talking, a lot of people may be drinking at these hazardous or harmful levels, but then there's a subset of people who really are drinking way above that. And in those instances, when you start getting the impression that alcohol is more of a controlling factor in what people are doing, and they're seeking out those opportunities to go out drinking with friends or to go out doing this with another group, that's when you need to be a little bit more careful and go into more detail in recommendations. And we look at this from the standpoint of what we do in collecting the information. That's kind of the screening side of things. But the next part is that brief intervention. And there we want to go beyond just the screening part and start to understand why people are drinking at these levels. And then if they are drinking at levels where the alcohol is now in control, they're craving the drinking, and they're beginning to develop physical dependence on alcohol so that they're drinking in the morning or they're having other situations of withdrawal or shakes when they're not drinking, then that's pretty good evidence that they have an alcohol use disorder. And we have options at that point. We can refer them to treatment. We can begin, to motivate them to seek help for this problem, or we can even consider prescribing pharmacotherapy. And there are drugs available, even in the setting of liver disease, that we can use. Naltrexone is one example. Acamprosate is another example. There's baclofen, there's gabapentin, there's topiramate. So we do have a few tools in the box these days. And once you get comfortable with how those drugs work and what their side effect profiles are, which are pretty reasonable profiles, really, we can either do that ourselves or we can refer them on to an addiction psychiatrist and get attention for those people.
I mean, I actually think, Mack, and I don't even do this very well myself yet, but I'm becoming more motivated. I actually think, even though I'm not an addiction trained specialist, I can probably figure out how to use some of these medications myself, like acamprosate. It's not that hard to use them. There are some monitoring recommendations that we use with some of these medications. And do you use any of these medications yourself, or do you involve an addiction specialist in every one of them?
Depends on the circumstances. I do use them. I will use acamprosate and naltrexone, for example. If we get to a point where somebody's really still struggling, even with the medications, and my motivation to attend AA or seek out other options for treatment, then I will refer them to an addiction psychiatrist. And I always ask them initially, would you like to go see an addiction psychiatrist? But surprisingly, not surprisingly, a lot of times people are more comfortable talking with me about that than they would be going to a psychiatrist. So that has a lot of other implications for some patients. They really don't think about them focusing just on the addiction, and they don't want to talk about what might have happened when they were growing up and all those kinds of things. So I try to meet people where they are in that regard. And if they're more comfortable with me prescribing the medications, we'll start there.
Yeah, I think it's a great idea. And I think providers that care for these patients should be much more aggressive and pick one or two out, learn about it, and prescribe it, because you'll actually help people, some people at least, and optimize their outcomes. Now, some people we fail. We don't for whatever reason intervene at an early time or successfully, and other people have never presented previously, and they actually present with severe alcohol-associated hepatitis. They have jaundice. They have ascites. It's new, or it may be recurrent. We have not had good therapies for this. I trained 30 years ago or more, and we didn't have great therapies then for this common problem. And now in the 2020s, we still don't. Do you see any new therapeutics on the horizon for alcohol-associated hepatitis, or are we still in the year 2055? Are we still going to be talking about how we don't have any therapies for this?
That's a really good point. I mean, there have been studies done over many years now trying to treat this very severe form of alcohol-associated liver disease. These are people that have a high risk of dying in the next 90 days. And we need to be careful that we don't just conclude that the only option for them is a transplant. While that may be true, particularly when you see somebody with a very high MELD score above 35, for example, transplant may be the only option they have. But for the other people who have MELD scores in that range of maybe 20 to 35, I think there are options. And, we are learning better how to use steroids. Prednisone, if you're going to use it, probably doesn't need to be used for the entire 28 days that we've used in the past. 7 days, if they have no response based on Lille criteria, stop, because you're going to put them at risk for infections if you continue. We've shown that to be the case in a lot of randomized studies.
And that's how these patients die.
And that's exactly right. That's how they die. So, but interestingly, some of those people with only 7 days seem to recover and do okay. Not always, but sometimes. The other new kid on the block really is larsucosterol. And there was a good randomized trial comparing that to standard of care. And the standard of care included steroids for some people, but not others. And the trial really, if you look just at the data from the United States, was positive. It showed a benefit of using larsucosterol. That's an interesting drug. It works in a fashion to modify epigenetically the expression of various genes and proteins and things like that. And it is doing something to speed the recovery of the liver. And it prevents people from dying. And those are two big factors, because the longer you can delay somebody dying, the more time you have to really work on the underlying alcohol use disorder. And the people that get to that point almost always do have an alcohol use disorder. So this is a different group of patients that are really heavy drinkers.
And I'll tell you one other thing, Mack, that I've been impressed with is in the last number of years, few years, there have been, to me at least, many more products with novel mechanisms of action that are being investigated in alcohol-associated hepatitis. In the 2000s, the 2010s, there was a study here and there, but it seems like in the 2020s, there are many, many different companies that are interested in this disease state. So I don't know if you've seen that, because you've done a lot of the research, but hopefully one of these mechanisms or more mechanisms of action will actually bear fruit. Have you seen more research in this field recently?
Yeah,
or
there's
with
a growing
agents?
interest in this, Steve, and you've been part of a lot of those trials as well. But there's a growing interest because this remains a serious problem with high mortality. So really there is yet an unmet need here. We did look at anakinra, which is a receptor blocker for interleukin-1. Older studies looked at tumor necrosis factor and infliximab treatment, and also Enbrel. Those studies led to more infections, and so kind of abandoned that. And unfortunately, although we had some initial promise for anakinra, it didn't really pan out in the end. So what's coming along now is another look at the cytokines. Interleukin-22 is an interesting cytokine because it seems to be hepatoprotective. It actually reduces the risk of infections, and it improves regeneration in the liver. So I think that's one possibility, but I know that the companies out there are very interested in this area now, and there's starting to be a lot more activity.
Yeah, and I think more activity will in fact have a positive outcome for us, and hopefully for the providers within the next several years, we'll have options for these patients that have severe alcohol-associated hepatitis, but not as severe as what you were talking about when patients present with MELD scores of greater than 35, because at that time it may be too late. And that leads us, I think, to one last important topic to discuss, and that is something that also has changed in the last 10 years or so, and that is offering liver transplantation for patients with severe alcohol-associated hepatitis that don't have a long period of sobriety prior to transplant. And clearly, when I trained, that was verboten. There was no transplant. If you weren't sober for 6 months, you're out. And that clearly has changed. And And there's some controversy about it now, and we're trying to figure out how to select patients appropriately for this. But what has your experience been in reviewing a lot of the data on a transplant of acute alcohol-associated hepatitis?
Well, Steve, you're right. I mean, we've known for a long time that there are some people who, when they first present, not having known that they had any problems with their liver, and they were just drinking at levels that were obviously way too high, but they weren't suffering a lot of social or other problems as a consequence of their drinking. When they present with the severe manifestations of alcohol-associated hepatitis, we began to look at them as a possible group that might benefit from transplant. And the folks in France, Philippe Mathurin and his colleagues, showed very clearly that there was a survival benefit in that carefully selected group. And I will emphasize carefully selected. That's since been replicated in the United States, work with that Brian Lee did, Andy Cameron, a lot of other pioneers in this field really showed that you could do that here in the U.S. as well. But you hit on exactly the right point, and that is, how do you select those people who are likely to benefit and not suffer consequences of ongoing problems related to their alcohol use? And that's a challenge. And I think we really need more good studies prospectively trying to identify what those factors are. And then we need studies that really tell us, how do you best manage the alcohol use disorder after a transplant?
That's exactly right, because our metrics, Mac, for determining success after transplant generally are 1 year graft survival and 1 year patient survival. And the initial studies showed, as you said, tremendous survival benefit for transplant. And that's not a surprise, because the patients that have severe alcohol-associated hepatitis with a MELD score greater than 35 don't live very long. We don't have good therapies. And yet, patients that have relapse into alcohol use disorder, they may have very poor outcomes a little bit later than 1 year. And I think you would agree, we haven't, in the liver transplant world in the US, generally done a very good job of addressing alcohol use disorder after liver transplantation. So what are your thoughts on that, and what we need to do after liver transplant to optimize these outcomes, maybe more than 1 year, maybe 2 years or 3 years out?
You know, it's an important area, not just for the alcohol use disorder, but for all of the other medical problems that the post-transplant patient has. And I think as internists, first and foremost, I think all hepatologists are really good internists, because you have to be. You have to understand all the other systems and how they work together to create some of the problems that we see with the liver, but also how the liver affects all those other problems. Having said that, I believe that we really do need a more integrated approach in the post-transplant setting, an integrated approach that incorporates our addiction psychiatry colleagues, that incorporates social workers, that incorporates addiction counselors, that incorporates the whole team and the family support system that individual has when they go through this big operation. And if we pay a lot more attention to those issues, particularly in the early phases after the transplant, but continue them on beyond that first year, I think we'll start to see better outcomes in the long term.
Well, that's great. Well, so I think in summary, Mac, for the providers, I think alcohol use disorder and alcohol use associated liver disease is increasing in prevalence and incidence in the United States. People that take care of patients with liver disease will see this more and more. We are not doing as good of a job on treating alcohol use disorder before or after liver transplant, and we probably should do better. Providers, I think, should get used to using some drugs to help diminish the alcohol recidivism rate, and also pay attention to a multidisciplinary approach for these patients. And when patients have severe alcohol-associated hepatitis, we still don't have great therapies, although corticosteroids should be used in appropriate individuals, but we think we're going to have more options. And And lastly, liver transplantation seems to be a growing field in a way in the treatment of acute alcohol-associated hepatitis and liver disease. And hopefully we're going to learn more about how to do that better. So we'd like to thank our viewers and have a good day.
Thank you.